Hello, my name is Megan Harbin, and I am a clinical pharmacy specialist in critical care at Vancouver General Hospital. I am honored to partake in this series named COVID-19, What Pharmacists Know Now, brought to you by the Canadian Society of Hospital Pharmacists, British Columbia branch. Today I will be discussing an ever-contentious topic in critical care, and that is corticosteroids. Specifically, I'll be discussing whether we should avoid them in patients with COVID pneumonia. I have no current or past relationships with commercial entities. The views in this presentation are that of my own and do not reflect those of CSHP-BC. And as you're fully aware, information about this pandemic is changing on a daily basis. So just note that the information provided in this presentation is up to date as of March 26, 2020. By the end of this session, the learner should be able to understand the current epidemiology of COVID-19, to be able to describe acute respiratory distress syndrome, ARDS, and the potential mechanism of corticosteroids for the treatment of ARDS, to be familiar with the available guidelines and their current recommendations for the use of steroids in COVID-19, and finally, to be able to make your own evidence-based decisions regarding the use of steroids in these patients. Thankfully, the majority of patients will have mild illness. Globally, we are seeing a case fatality rate of around 4.5%. And in places such as Italy right now, we're seeing numbers as high as 10%. Currently, in our own backyard, the case fatality rate is reported around 1%. These numbers, of course, may fluctuate based on the testing strategies employed across the provinces. Patients who present with more severe illness, not surprisingly, are at higher risk of respiratory failure, progression to ARDS, and mortality. This graph highlights the stages of disease that patients may progress through once infected with COVID-19. As mentioned earlier, the majority of patients will present with mild viral symptoms such as fever, cough, headache, and occasionally GI symptoms, and the illness will typically end here. It is in our older patients or those with comorbidities that we are seeing progression to developing shortness of breath and hypoxemia. What is most concerning about COVID-19 is that the patients we are seeing entering stage 3 or the hyperinflammation phase are those that are at highest risk of mortality from ARDS, shock, and cardiac failure. ARDS is defined as an acute diffuse inflammatory form of lung injury, the cause of which can be the result of direct lung injury from either bacterial or viral pneumonia, or indirectly from conditions that elicit a systemic inflammatory response, such as sepsis. According to the Berlin definition, to meet ARDS criteria, the onset of symptoms must have occurred within 7 days of the known clinical insult. On imaging, you would expect to find bilateral opacities consistent with pulmonary edema, and by definition, cardiogenic pulmonary edema should be ruled out. ARDS is further characterized into mild, moderate, or severe based on the PF ratio, and that is the partial pressure of arterial oxygen to the fraction of inspired oxygen. Not surprisingly, the lower the ratio, the higher rates of mortality, with severe ARDS resulting in 45% mortality rate. The caveat to these PF ratios is that patients must be on positive pressure ventilation at a minimum of 5 centimeters of water. In the early or exudative phase of ARDS, the host response is to release a number of pro-inflammatory cytokines. This cascade of events leads to sloughing of epithelial cells, breakdown in the basement membranes, and as a result, a number of inflammatory cells and fluid can leak into the alveoli, resulting in pulmonary edema and inflammation. Therefore, the thought is that if we use corticosteroids, we may be able to blunt this inflammatory cascade by downregulation of pro-inflammatory cytokines and upregulation of endogenous anti-inflammatory cytokines. Before delving into COVID-19 specific literature, I would like to review what we currently know about the use of corticosteroids in ARDS patients. In this Cochrane review published in 2019, the authors found that compared to control, corticosteroids resulted in a non-statistically significant reduction in mortality. This could not exclude a relative risk increase of about 5%. The authors included trials that were published after the ARDS-NET trial, and that was to ensure that all patients would have been receiving lung protective ventilation strategies, which have been shown to reduce mortality in ARDS. The Steinberg 2006 trial included in this review found that if corticosteroids were started beyond 14 days of ARDS onset, there was an increase in mortality. Though this is not clear as to the reasons why, it is likely due to the fact that the injury has already progressed to the fibrotic stages of ARDS, where corticosteroids are unlikely to be of benefit and we're more likely to see the harms. With respect to the duration of mechanical ventilation, again we see a non-statistically significant reduction by about 4 days favoring corticosteroid. Of note, this analysis found a significant statistical heterogeneity, which the authors could not explain. Since the publication of the Cochrane Review, there has been one new RCT which was designed to assess the efficacy of dexamethasone versus standard of care in patients with early ARDS. This was a multicentre randomised open-label trial enrolling 277 patients with ARDS. The average age was 57, and 69% were males. The duration between the diagnosis of ARDS and entry into the trial was about 1 day. Pneumonia and sepsis were the predominant reasons for patients developing ARDS in this trial, and the average PF ratios were 142, corresponding to moderate ARDS. This trial took place between March 2013 and December 2018, where it was stopped early secondary to low enrollment. 62% of patients were excluded from this trial based on pregnancy, terminal malignancy, severe COPD, CHF, or current receipt of corticosteroids or immunosuppressants. Patients were randomized to receive dexamethasone versus standard of care. In the dexamethasone arm, on days 1 to 5, patients received 20 mg IV daily, and then on days 6 to 10, they received 10 mg IV daily, so a total duration of 10 days of corticosteroids. Co-interventions included lung protective mechanical ventilation, and at the discretion of the attending, patients could have received prone positioning, recruitment maneuvers, sedation, and neuromuscular blockade. Compared to standard of care, dexamethasone resulted in an increased number of ventilator-free days at day 28 and a reduction in all-cause mortality assessed at day 60, with the number needed to treat of 7 to prevent 1 death. In terms of adverse events, they found no statistically significant difference between the groups for hyperglycemia or new infections. Of course, major limitations of this trial include the open-label nature and the fact that it was stopped early, and as such, results may be exaggerated. Despite this, this is the largest trial we have done in the post-ARDS-NET era, and it does contribute to the literature supporting steroids in early ARDS. Now let's move on to the available evidence for corticosteroids in COVID-19 induced ARDS. First up, we have a retrospective cohort published in JAMA in February 2020. The authors included 201 COVID-positive patients with a median age of 51 and 64% were males admitted to a single hospital in Wuhan, China between December 25th and January 26th. Of the patients included, the majority were supported with oxygen via nasal prong. 30% required non-invasive mechanical ventilation, and only 2.5% required mechanical ventilation. 0.5% of patients received ECMO. 31% of patients received methylprednisolone with a median dose of 65 milligrams. Not surprisingly, the majority of patients received antibiotics, and 85% received antivirals. Other therapies included immunomodulator therapies such as IVIG, and antioxidants such as glutathione were used. Outcomes assessed as of February 13, 2020, included a median length of stay of 13 days for these patients. 26% were admitted to ICU, 42% had developed ARDS. However, the authors did not comment on the definition of ARDS or what the patient's PF ratios were to qualify. 22% of patients died in this cohort. The authors looked at risk factors for development of ARDS and death and found that age was associated with a significant increase in ARDS and death. Hypertension and diabetes were both risk factors for ARDS, but interestingly not death. When looking specifically at the ARDS patients, those who received methylprednisolone versus those who did not, they found a hazard ratio of 0.38 in support of methylprednisolone. Next up is the second and only other publication looking at corticosteroid treatment in patients with severe COVID pneumonia. This was a retrospective cohort including 46 patients with a median age of 54 years. 57% were males and 30% of them had hypertension. Other comorbidities included coronary artery disease, diabetes, chronic lung disease, cerebrovascular disease, and malignancy. Patients were admitted to Wuhan Union Hospital between January 20th and February 25th, 2020. 26 patients received methylprednisolone at a dose of 1 to 2 milligrams per kilogram per day for about 5 to 7 days. Specific dose was determined based on clinical and laboratory findings. 20 patients received standard of care. Co-interventions included oxygen supplementation, of course, antivirals, and antibiotics. In terms of the outcomes, 2 patients who had received methylprednisolone died, compared to 1 in the standard of care arm. The authors note that the duration of supplemental oxygen was shorter for those who received corticosteroids versus those who did not. Unfortunately, we have no data about the amount of oxygen received and certainly what their oxygen saturation goals were. 43 out of 46 patients were discharged alive. There are a number of limitations that are worth mentioning for both of these publications. They were retrospective observational cohorts with relatively small numbers. Selection bias, more specifically confounding by indication, would have been present in both, as clinicians are more likely to prescribe steroids to those patients at highest risk of death, and therefore the groups are no longer comparable at baseline. Performance and detection bias were not accounted for, and certainly clinicians would not have been blinded. There was no adjustment made for immortal time bias. Essentially, patients who received methylprednisolone, by definition, had to survive long enough to receive treatment, and therefore this can lead to the false belief that treatment is associated with an improvement in the outcome, which was mortality. Reporting bias was also present, as the authors did not report any adverse events associated with treatment or not. In terms of external validity, of course, these were 2 single centers in Wuhan, China, in the midst of a pandemic. There were a limited number of patients included with moderate to severe ARDS. And certainly in the latter publication, the majority of patients only received supplemental oxygen. It is unclear the utilization of evidence-based ARDS management strategies such as low tidal volumes or prone ventilation. We've reviewed the potential efficacy of corticosteroids, so what is the downside? There are a number of adverse events associated with corticosteroid use. In this table, I have bolded the more common side effects that are often occurring within the first hours to days of starting corticosteroids. We certainly see delirium, psychosis, and insomnia with corticosteroid use anecdotally. Hypertension and fluid retention are often desired effects of corticosteroids when we start them for septic shock. Hypernatremia and hypokalemia can occur. And certainly we do see hyperglycemia with corticosteroid use. The question of bacterial or fungal infections certainly is a concern. However, multiple RCTs do not seem to highlight this as a major risk with corticosteroids. However, this is often a secondary outcome and perhaps just not powered enough to find a difference. So what is the risk in viral pneumonia? There is possible increase in mortality for influenza pneumonia, and we saw that from a Cochrane review looking at 5 studies, and they found an increase adjusted odds ratio of 2.23. Another study looking at the H1N1 pandemic in 2009 across 51 Canadian ICUs, adjusting for time-dependent variables, and it was propensity matched, found no difference in mortality. With respect to the SARS and MERS pandemic, there's been no difference found in mortality with corticosteroids. However, there have been reports of increased adverse events and delayed viral clearance. With respect to the COVID-19 pandemic, the data we have so far is telling us that, again, corticosteroids may lead to prolonged viral shedding. So in summary, for patients with ARDS from various different causes, corticosteroids likely result in a reduction in short-term mortality and duration of mechanical ventilation at the cost of increased adverse events. Prior data on steroids and viral pneumonia and ARDS are conflicting due to potential increase in mortality. However, this is more likely due to confounding by indication in these situations. The ultimate downside in viral pneumonias and ARDS is the potential for prolonged viral shedding in addition to the usual harms. And finally, for COVID-19 induced ARDS, we currently do not have high-quality data to inform us regarding the potential benefits or harms of corticosteroids in this patient population. So what do our major guidelines say? The Center for Disease Control and Prevention, as of March 7, 2020, stated that corticosteroids should be avoided because of the potential for prolonged viral replication as seen in MERS. The World Health Organization has released version 2 of their guidelines, updated March 13, 2020, and their position is to not routinely give systemic corticosteroids for viral pneumonia outside of clinical trials. And they actually prioritize saying that it should be studied in a clinical trial. The Australian and New Zealand Intensive Care Society, as of March 16, 2020, also recommended against the routine use of steroids for acute respiratory failure. They do note that some patients may have other clinical indications for the use of steroids, such as septic shock. Next up, the Society of Critical Care Medicine published guidelines on March 20th, 2020, and they stated 3 following recommendations. For those patients with COVID-19 and respiratory failure without ARDS, they suggest against the routine use of systemic corticosteroids. For those with COVID-19 and ARDS present, they do suggest using systemic corticosteroids over not using them. Both of these recommendations are weak and low quality evidence. And third, they state that for patients with COVID-19 and refractory shock, they suggest using low-dose corticosteroids over no corticosteroid therapy. And finally, the BC Centre for Disease Control released guidelines that were put together by a clinical reference group made up of many physicians and pharmacists that I have the privilege of working with. And on March 24th, 2020, their statement regarding corticosteroids is to recommend against the use. However, they may be considered if a compelling indication is present, such as asthma exacerbation or refractory septic shock. Based on the limited evidence of benefit and known harms associated with corticosteroids, I do support the recommendation of most guidelines to not routinely prescribe corticosteroids in COVID-19 patients. Ideally, the role of corticosteroids in moderate to severe ARDS patients with COVID-19 would be addressed in a randomized controlled trial to eliminate the biases that I had discussed previously. In the absence of such data, you could consider corticosteroids carefully in the following critically ill COVID-19 patient populations: those with refractory septic shock, where we do have evidence of benefit with low-dose hydrocortisone, resulting in a reduction in vasopressor use and possibly mortality. In those patients with concomitant indications for corticosteroids, such as COPD or asthma. And finally, the burning question of whether to use in severe ARDS patients. Unfortunately, this still remains a contentious issue, leaving many clinicians unsure about what to do. I personally, at this time, based on extrapolated data from the ARDS literature, would consider corticosteroids in patients who are failing maximum ventilatory support, after weighing the risk and benefits of such therapies with the intensivists that I work with. In closing, I would like to thank CSHP-BC branch for this opportunity, and to everyone out there helping to provide essential services during this time. Thank you for being brave and helping us all flatten the curve. I would be happy to take any questions or comments you have via email. Thank you.